Welcome to the EHA Myth-Busting podcast series, and thank you to everyone for listening. I'm Gareth Tucker, the CEO of a leading medical communications group, and I'll be your host for this podcast. This is the fifth and final podcast in a comprehensive 5-part series funded by the European Hematology Association, discussing hematology diseases, diagnosis, assessment, and treatment in older adults. The purpose of the podcast series is to share up-to-date information with patients and physicians about hematology in older adults. To access the other podcasts and associated resources, please visit the EHA campus at www.ehaweb.org. Today, we're discussing the ethical issues associated with treating hematological malignancies in older adults. Our experts for this discussion are Professor Raul Cordoba, Dr Ulrich Wedding, and Professor Dominique Bron. Perhaps if I can come to you first, Professor Cordoba, would you like to introduce yourself?
Yes, thank you very much. My name is Raul Cordoba. I am the chairman of the Scientific Working Group on Aging and Hematology since 2019. And I am also a member of the Spanish group of Geriatric Hematology. So I am very much involved in treating and addressing all issues of older adults with hematological malignancies. So it's for me a great honor to coordinate this program in the EHA campus, and I hope to have a very successful conversation with my other two colleagues and also friends.
Thank you, Professor Cordoba. And Dr. Wedding?
Yeah, my name is Ulrich Wedding. I'm a specialist for internal medicine, medical oncology, and hematology, and I'm head of the Department of Palliative Care at the Jena University Hospital in Germany. I'm involved in several working groups on geriatric oncology, geriatric hematology, and I'm happy to hear and to discuss with Raul and Dominique.
Thank you. Professor Bron?
Yes, I am Dominique Bron. I am professor of hematology at the Free University of Brussels in Belgium and just retired as head of department of hematology in Cancer Institute in Brussels. I have a special interest in aging and ethics and bioethics in medicine, and I am a member of the scientific working group from the EHA on aging with Raul and Ulrich, and happy to be here for the discussion.
Excellent, and thank you to all three of you for participating. So let's move straight into our first set of questions, and we have a couple of patient-centric questions to kick off with. And the first is around how are decisions actually made regarding an individual patient's treatment pathways in older adults, and how much of a say does the patient have in their own treatment? Is it affected by their age? Maybe Professor Cordoba, I could ask you to comment on that first.
Yes, thank you very much for this question. When we are seeing a patient in our clinic, when this patient is an older adult, we should look not only to the age of the patient, but to other conditions. So when we want to decide a treatment, the first thing I think that we have to meet is to share the goal with our patient. We have to make a shared decision process because at the end, we are treating patients with diseases and not diseases. So to share a common goal with the patient is very important in this case. And also when we have this goal, we have to check for different conditions rather than age by itself. And we should proceed to a comprehensive geriatric assessment. In many institutions, we do not have geriatricians to do this comprehensive assessment, and there are many proposals to do a screening of frailty in order to identify which patients are going to benefit from a further comprehensive assessment. And those that which are referred to the geriatrician, this specialist is going to be part of the team, because at the end we are going to be part of a multidisciplinary team. And this specialist is going to check not only for comorbidities, as we are used to do in our clinics, but also for a social, nutritional, emotional, and psychological status. And the geriatrician is going to be able to classify patient into different subtype of frailty, and it's going to help us in order to tailor therapy according to frailty, not only to age.
And as we start to maybe lean more towards some of the ethical questions, how much of an impact does cost have on treatment decisions? And are older patients maybe more likely to miss out on treatment options than their younger counterparts? Maybe Dr. Wedding, I could ask you to comment on that.
There are it might be that the situation is different in different countries. I'm not aware of all regulations in all European or worldwide countries. At least in my country, there is no rule that age is a factor for not offering a treatment to the patient, age itself. But the clinical benefit might be different between younger and older patients, and the risk of the treatment might be different between younger or older patients. And the risk of treatment is a factor which is important for your treatment recommendation to the patient. The main question is, will the patient be able to benefit from the treatment, or will you possibly harm the patient? And it's not a good treatment when you harm the patient. But the costs are not the relevant decision-making criteria within this process of decision-making.
Thank you, Dr. Wedding. Professor Bron, is there anything you would add? We touched on the sort of shared goal approach, the importance of appropriate treatment. Obviously, the question was, I suppose, also around the slightly ethical side of whether age might have an impact on treatment decisions. Is there anything that you would add to what's been already said?
I fully agree with my colleague. Maybe what I would say is that it's true that the older patient, they are often undertreated, and usually it's not for financial reason, but there is a myth around aging and older patient. It's that older patient, they are frail, and usually what you heard is that the family says that the patient is not able to tolerate the treatment, and the fear of the patient is the loss of autonomy, and the fear of the physician is the toxic death, the risk to kill the patient. And then they both are happy by reducing the doses, and that's what we observed in the real life, is that the physician, they reduce the doses, whatever the comorbidities, and what Raul explained, that we don't do that when you are a good oncogeriatrist. You do the geriatric assessment and you adapt to the vulnerabilities. But in the real life, patients are usually undertreated because of these two myths.
I think we see both. There's undertreatment, and in some patients there's overtreatment as well. So it's difficult to have the right balance between both. You want to avoid undertreatment. You want to be able to offer the patient the treatment he can benefit from. And in some patients, some relatives, in some physicians, there is a fear of that you toxify the cause of the disease without benefit. And on the other hand, I see overtreatment as well. For example, in long-lasting disease with several treatment lines, it's always difficult to find the right moment when you don't offer a further treatment and stop treatment, and the patients will more benefit from supportive care only.
Professor Cordoba, what would be your thoughts around this sort of balance of overtreatment and undertreatment?
Yes, I want to add that I think geriatric hematology is here to help in this decision process. If we identify a patient which is classified as fit, I think it's relevant not to undertreat a fit patient. But if we identify and classify the patient as vulnerable or frail, it's very important not to overtreat this patient. So we know that we do not have to under or overtreat a certain patient, but geriatric hematology is here to help in order to tailor therapy. So I think we have to start implementing these strategies in our daily clinical practice, just to tailor and to adapt the treatment to all different phenotypes and features of our patients.
Thank you. And I think we're sort of moving into the main area, the nub of the area around why there are so many ethical issues around treating older adults. Maybe Professor Bron, maybe you could comment on this to start with.
Yes, thank you. It's a very good question, and we don't talk enough about the ethical problems in medicine. And before to start with the problem, I would like to remind you that there is 4 principles in ethics in medicine. The first one is no maleficence. Then we should not harm the patient. And for older patient we are discussing now, it's to balance the benefit and the toxicity, for instance, and not to be too toxic with the patient. The second issue is beneficence. Then you have to do good with your patient. You have to take care of the disease, but you don't have to forget the patient. Around the disease, and then you should be sure all the depression, the nutritional problem are covered. We have to avoid any discrimination by age. We have to be sure the patient understood what we said, and that's the second point. And beside no maleficence and beneficence, the third point is the respect of the patient autonomy and self-determination of the patient. And it's well known that for all the patients, the quality of life is much more important than the quantity of life. And it's very important when we have discussed together with physician and geriatrician and psychologist the best treatment for the patient. It's very important to discuss with him about his personal vision in terms of life, quality of life, and also end of life. That's for the third point. And the fourth point, it's very important today in this COVID period, is the social justice. And this social justice sometimes is not easy to discuss, but when we have a limited budget or limited resources in some acute situation, it's very important to balance the cost and the benefit ratio we can apply to the patient. And then it's very important to have some real objective clinical frailty scale score and to know the life expectancy of the patient.
Thank you, Professor Bron. I know you described these in Module 1 of the Myth-busting e-learning series accompanying this podcast. So listeners can access these at the EHA campus at www.ehaweb.org. Dr. Wedding, would you like to come in there?
Yeah, I think it's important to ask ourselves as physicians, are there areas where we, knowing or unknowing, apply ageism, that we don't look at older patients as careful as we do for younger ones. And I know a study performed in Norway where general practitioners, specialists in hospitals, and students were asked for the image of medical disciplines. At the top of the line, there were cardiac surgery, neurosurgery, and at the bottom line, there was geriatric medicine. And that was independent whether the setting were GPs or specialists in hospital or medical students. So it was independent of the setting and independent of the amount of training they had. So we, in some areas of medicine, are more in favor than others. And caring for older people is not as interesting as other things in medicine to do. And another example is how are we willing to offer medical trials for patients, and we are more enthusiastic to offer clinical trials to younger patients than to older patients. General practitioners are more interested to send younger patients to the centers where they are cared for the best way, and they're more reluctant to refer older patients to centers. So there are a couple of examples where we practice some discrimination due to age in patients in medicine.
Yes, multifaceted challenges. Professor Bron, you alluded to this just now around the COVID-19 pandemic. How has the pandemic exacerbated these kind of ethical issues?
Oh, there were a lot of ethical issues, and we retrospectively have to analyze all the failure and deficiencies in the system. But the problem of social justice, as I discussed in the ethical problem, became prominent in this COVID period because we had a shortage of material, the mask, the gloves, the oxygen provided. We had a shortage of medication for the patient. When we decided to have palliative care instead of ICU, there were not enough pain relief medication or other medication. That was a problem. During this period, we realized there is a very bad coordination between the nursing home and the hospital. There were no clear guidelines, no clear connection. And we are analyzing all these problems today. And the last ethical problem really acute during this period is the solitude of the older patient for the end of life, because they were far from the family, far from the children, without any contact. And older patients, they are not so familiar with the tablets, and it was really an ethical problem to have all this older patient dying far from the family.
Many challenges, and maybe I can come to Professor Cordoba next. Professor Bron's outlined some of those issues, and the poor coordination, the patient solitude. I mean, thinking more broadly, how has the COVID-19 pandemic impacted patients with hematological malignancies?
In the UHA, we have conducted a retrospective study about what we did in the pandemic. As Dr. Bron has said, we made things that were not in the best way, but we learned about how to improve the healthcare of our patients. In this study called EPICOVID-EHA, almost 4,000 patients were recruited in this study, and almost 2/3 of patients had a severe disease. And almost 1/3 of patients died because of COVID-19. So at the end, many patients died because of this infection, not only because of the hematological malignancy. And when we analyzed what happened to these patients, age by itself was a poor prognostic factor for outcome. And probably it could be related not because of the age by itself, but because of the lack of functional reserve. We have to keep in mind that many patients were in the need to ICU admission. Many patients were in the need of a high flux of oxygen, in the need of drugs to keep blood pressure. And in the lack of resources, we had to look for the best candidates in order to obtain the best outcome. I think that in many cases, the age was the only factor that was taken into account in order to decide if the patient was admitted to an ICU or not. But if you check all the scores or calculators that are available in order to predict the outcome when a patient with a COVID-19 infection may have, probably the age by itself is one of the more strong predictive factors. And of course, in this pandemic, it has to be taken into account.
So what would you say were the broader reasons then for some of these, maybe so poor outcomes or the difficult outcomes in COVID-infected patients with hematological malignancies? What was behind it then, maybe beyond just age?
When we check for the different risk factors, one of them is the diagnosis by itself, not only the age. And we have seen in this study that patients with acute myeloid leukemias and myelodysplastic syndromes were at higher risk of death just because of having this diagnosis at the time of suffering from COVID-19 infection. And also to be in active treatment, it could be related to an impairment in the immunity or in the way of fight against the infection. These patients on active treatment due to the hematological malignancies were at higher risk of suffering from a severe infections and afterwards of death. So not only age, but the diagnosis, being on active treatment, comorbidities. As long as we age, we are going to suffer from more diseases, and we are going to have more conditions that can impact in a final one, like the COVID-19 infection or the hematological malignancy. So many factors have to be taken into account in order to try to predict the outcome.
Thank you, Professor Cordoba. I'd like to come back to a topic we touched on just now, which is around things like pressure on ICU beds. And maybe I can come to Dr. Wedding first. When there is this kind of extreme pressure on ICU beds, such as during this global pandemic, how are decisions made on who should get a bed? And what is the impact of hematological malignancy in this decision-making process?
Yeah, normally we make decisions within medicine asking two questions. First question is, is there a treatment which will be able to improve the course of the disease for the patient? We call it indication, or is there a need for medical treatment? And the other part is the patient willing to have this treatment? And both have to come together to that we start treatment. And in the situation of a shortage of ICU beds or ability to have high flow oxygen or ventilation, we have to add a further point. We have patients who would benefit from the treatment and who would be willing to take the treatment, but we can't offer the treatment because it's not available due to a shortage of material, but in most of the cases due to a shortage of persons who are able to apply the treatment. And when we have to make the decision in this situation, it's important to inform all members of the decision team that we have such a situation. That we have to prioritize between different kind of patients who will benefit most of the treatment, and to apply the treatment to the patient who will benefit most, and then you have to communicate with the other patient and their relatives that you can't offer the treatment due to a shortage. And then that you offer best supportive care, including palliative care in this situation. But we have to compare not only patients affected by a COVID infection, but we have to compare COVID patients with trauma patients, with oncological patients, with hematological patients, with COPD patients. And that's a thing we are not used to compare between the different diseases, the most likely clinical benefit the patients have from the ICU care. And then we have to come together in a team to discuss the likelihood of benefit from the treatment, and then to make a decision. it's important to first to have the official statement that we are in a situation where we have to prioritize, and second, that the team is coming together and make the decision based of rules they have decided on in a first stage, so that you have a transparent approach, even in the situation of shortage of ICU care, of ventilation or anything.
So I'd be interested whether there were local, I guess, geographic differences. Dr. Wedding, you touched on this sort of cross comparison across disorders, this broad team evaluation. Maybe Professor Bron, was that a similar situation in Belgium?
Yeah, I think the situation was similar in all the European countries and also in the US. And we also learned from the acute shortage of bed in the ICU, as Ulrich explained. It's not easy to prioritize the patient. That was a real ethical problem during this period. And we learned from the regulation of the ICU. It was published in the New England Journal of Medicine in March 2020 by Ezekiel, and they explain that it's important for the care of the patient, not first come, first served. That's not something they can't apply in an acute situation, and we have to be careful. And for the older patient in the nursing home, they explain that it's important to discuss with at least 2, ideally 3 physicians, including geriatrician. Age is not a criteria. It's important to have in the file of the patient advanced care plan, and usually that's missing. It's important that the caregivers in the nursing home are able to establish the clinical frailty score. It's used in the ICU, and it's also used by a geriatrician. Because of this clinical frailty score, it's done in 5 minutes, and it can help to decide we do or we don't do intensive medicine. It's important to take into account if there are other disease like end-stage renal disease or end-stage cancer to stop the transfer to the hospital. And what they explain in this editorial too, it's something that Ulrich already mentioned too. It's important to keep a registry of this decision, because it's difficult to do this selection of the patient, and it's important to learn afterwards from what we did. And it's also important to have a psychological support for the physician who are involved in this selection and the way to prioritize. Then it was an important paper in the New England Journal of Medicine published related to this triage.
So, Wedding, you wanted to add in onto that?
Yeah. At least in my country, there is no law which allows us to decide based on triage. But as physicians, we recommend to do this, and we as within the medical societies, we try to provide rules how to perform it, and not to make decision only based on first come, first serve. The difficulty in the decision-making process is, in addition, that a ICU capacity or a ventilation capacity you need for a COVID patient is a long time period. You have to, most of them are ventilated for 3 weeks or 4 weeks. And are you allowed to include in your decision-making process? You might need the ventilation capacity for other patients with other diseases only for 5 days or a week. And can you offer the same ICU capacity to 4 patients instead of 1. We don't know whether that we are allowed to do that, and whether it's appropriate to include the time you need the ICU resources to include that in your decision-making process.
Indeed. Finally, maybe if I can come to Professor Cordoba, I assume the situation was similar in Spain. It'd be interesting to get any thoughts or insights from yourself, I guess, particularly if there's anything else around the sort of hematological malignancy perspective, or whether it was very much the same around the same sort of challenges of prioritization.
I think in the field of hematological malignancies, when we had a patient in order to be transferred to the ICU, one of the questions that we are very frequently asked is about the prognosis of the hematological malignancy, is if the patient is with the disease under control, or if it's in the relapse setting, trying to get the malignancy into control or not, if the patient is on active treatment, and what's the prognosis with this patient besides COVID-19. So if the patient, our goal is to cure this patient or to achieve a very long-term remission, or if the outcome is going to be poor, just in case, for example, of a relapsing or chemorefractory acute myeloid leukemia. So these questions are also taken into account in order to decide which patients are going to be transferred to the ICU. And as already mentioned, there are many scores and calculators that can be used in order to identify which patients can benefit the most. And for example, in Spain, many calculators have been developed, also one in my institution, and it has been used based on all the data using artificial intelligence with machine learning strategies in order to at least try to help us which patients benefited in the past of being admitted into the ICU, and to take into account these factors also with the prognosis of the hematological malignancy. So at the end, 2 main group of factors, one coming from the general population and the other coming from the situation of the hematological malignancy.
Excellent, thank you. I guess what all of you have described up to a point is the importance of the individual patient assessment being key in the decision-making process. Professor Bron, I understand you're part of an expert committee in Belgium that's compiling a document to help improve patient evaluation during situations such as a pandemic. Please, would you tell us a little bit more about the work you've been doing and what you're hoping to achieve?
It was a long story. Then we were approached by the Ministry of Health because everyone was shocked, like in the other country, by the deficiencies and the failure in the system. Then we established, we have a National Committee on Bioethics. It's running for now more than 20 years, composed of physicians, lawyers, psychologists, sociologists, epidemiologists, a lot of different expertise. And then we created a specific commission of experts for this problem in the nursing home and how to be more human for the next acute problem in the future, because this time it was a pandemic, but it could be an earthquake, it could be flooding, it could be nuclear attack. We have to be now prepared for other acute problems and the management of all the patients in our society. Then after the interviews, I can take 1 hour, but I will summarize the recommendation. Then after all these interviews, we ended with a recommendation in 3 different directions. Then the first one was improvement in the infrastructure because of the shortage of material, and also to have a better coordination between the nursing home, the hospital, less general practitioner linked to the nursing home. The second direction was an improvement in the training of the caregivers, the nurses, the physician, to have a better emergency plan and a better training for the evaluation of the frailty score, to know which of the patient have to be sent to the hospital or not, and also to investigate the patient. And that's the third direction. It's improvement in the file, the numerical file of the patient, and this file of the patient in the nursing home should include a better evaluation of the vulnerabilities and the frailties, the clinical frailty score of the patient, a better overview of the patient wishes in terms of end of life. And that was the situation for Belgium. I cannot say if the situation in all the countries, but this national committee is just a consulting committee without any legal authorities, and they just to suggest the thing to improve. And as we discussed already with Raul and Ulrich, maybe it would be good to discuss on a European level and to have more practical approach maybe in the future.
Very interesting. Will the document be made more widely available?
Yeah, I just asked to this committee, then it's now published in the website of the National Committee. And if you refer to this advice of this opinion, then there is no problem to use it for other purpose.
Excellent, thank you. That brings us to the end of this podcast. Thank you to Professor Raul Cordoba, Dr. Ulrich Wedding, and Professor Dominique Bron for their insights and expertise on the ethical issues associated with treating hematological malignancies in older patients. They summarized the great number of ethical challenges associated with the treatment, not least prioritizing access to care, managing the very individualized requirements of all patients, and balancing things such as over and under treatment, but also the ethical challenges that have been perpetuated by the COVID pandemic. Thank you also to everyone for listening. Please do remember that you can access the other podcasts in the EHA Myth-Busting series, alongside the other associated resources at the EHA campus at www.ehaweb.org. Thank you for listening.